Hello everyone, let's see mucoepidermoid carcinoma. It is a malignant epithelial tumor that arises from the salivary gland tissue. As the name suggests, muco, so it is composed of mucus secreting cells and epidermoid type of cells in varying proportion. Columnar and clear cells may also be present. The two important features to remember are it shows prominent cystic growth and it is not completely encapsulated. Now let's see the prevalence. It is the most common malignant neoplasm in major and minor salivary glands. It is most common salivary gland malignancy in children and it is 5% of all the salivary gland tumors. The most common site is parotid gland. It is more common in females and it is seen in any age but usually between 3rd and 5th decade. The pathogenesis is uncertain and radiation exposure may be a risk factor. We saw the most common site is parotid gland. It is usually asymptomatic swelling and it is rarely more than 5 cm. So, most patients may be aware of the lesion from 1 year or they may know that there is a mass from many years. But because it is a asymptomatic swelling, the patient may not show up with a complaint. Pain or facial nerve palsy may develop because it is usually associated with a high-grade tumor. The second most common site is minor salivary glands, and out of this minor salivary glands, palate is the most common site. Here also there will be asymptomatic swelling, sometimes fluctuant, and it is red-blue in color, so it can be mistaken for a mucocele. Now let's see the histopathology. There are 3 types of cells. First is the mucus cells. Mucus cells, these vary in shape. They have abundant foamy cytoplasm and they stain positively with mucin stain. Second is the epidermoid cells. These have squamoid features, polygonal in shape, intercellular bridges are present and they rarely show keratinization. These have squamoid features but they do not show keratinization. Third is the intermediate cells. These intermediate cells, these are important for diagnosis and these are believed to be the progenitors of other 2 cells. That is, they are believed that these make the mucus cells and the epidermoid cells. These intermediate cells are highly prolific baseloid cells. These are larger than basal cells but these are smaller than squamous cells. Now, on the basis of these 3 features, we have divided these into 3 grades. So, let's see the features. First is the amount of cyst formation, second is the cellular atypia, and third is the relative number of mucus, epidermoid and intermediate cell, that is which cells predominate. So, first let's see the low grade. In low grade, there is more cyst formation. There will be prominent cyst formation because there is low grade. So, there will be less variation than the normal. So, there will be minimal cellular atypia and more number of mucus cells. More mucus cells, less cellular atypia and more prominent cyst formation. Second is the intermediate cell. Obviously, in intermediate, it will be in the middle of the low grade and the high grade. So, in this cyst formation will be present, but it will be less prominent than the low grade. All 3 major cells will be present, but intermediate cells will predominate, and cellular atypia may or may not be seen. Then the third and the last is the high-grade tumor. In this, solid islands of squamous and intermediate cells is seen. Because it is high grade, so there will be more variation than normal. So there will be much considerable eomorphic and mitotic activity and there will be less mucus cells. So there are less mucus cells and more epidermoid cells. So this more epidermoid cells will make it difficult to distinguish it from the squamous cell carcinoma. Now let's see the diagram. This is the cystic space. And in the cystic space, we will show mucin. And these are the mucin producing cells. These are the mucin producing cells. These are the epidermoid cells. These are the intermediate cells. How intermediate cells should look? We have to show scanty cytoplasm and a bigger nucleus. Here also we have shown the mucin pooled area. Now let's see the treatment. For parotid gland, we have to see that if possible, we have to preserve the facial nerve. Usually in the low and intermediate grade. For high grade, we will go for the radicular neck dissection. That is, if there is a cervical node metastasis or any patient with T3 lesion, radicular neck dissection is done. And if some mandibular gland is affected, then the entire gland has to be removed entirely. So in minor salivary gland, this was for the major salivary gland, that is for the parotid gland, the submandibular gland, and if there is metastasis, then we will go for radicular neck dissection. Now for the minor salivary gland, primarily surgery is the option, but some investigators have recommended post-operative irradiation and few studies recommend chemotherapy. Two variants of this tumor are sclerosing mucoepidermoid carcinoma and intraosseous mucoepidermoid carcinoma. This was all. If you found this video helpful, do like and subscribe. Thank you.